Okay, case number one. So this is a 15-year-old male with foot pain, foot and ankle pain. He had an injury a few months ago, more proximally, but that injury healed up just fine. And what we have is just ankle radiographs here initially. And what we said was, well, we don't see any new fractures, but there is a lot of osteopenia, and maybe there's some atrophy of the skin around there. Let's get an MRI to see what's going on. And I just have two selective images, sagittal T1 and stir on the left, T1 on the right, with sort of this diffuse area of increased signal in the bony structures of the tarsals and a little bit metatarsal. I just give you one slice because this is the most representative. There's also abnormality in the distal tibia. I just don't show it to you in this particular slice. And there's also a little bit of edema and increased signal in the dorsal soft tissues. Further on down the foot, there was also some dorsal soft tissue thickening and edema. So any thoughts on what this is?
How long is the pain?
The pain is going on for several months, and like I said, prior to this, he'd had an injury more proximally in the I think the fibula or the tibia, and that had healed up. And at first, I was thinking, well, could this be diffuse osteopenia? But the kid was not particularly inactive after the injury was all healed.
Is this something that he underwent physical therapy and still did not improve? Because regional pain syndrome can look like, a lot of multiple bone edema, usually peripheral. with large
Yeah, no,
tarsal bones.
that's a great thought, Amisha, and that's what we were thinking. The patient did undergo physical therapy, and with no recovery really. So we sort of said, there's no specific finding in imaging that rules in or rules out chronic regional pain syndrome, but this is consistent with that history, and so that's what we called it. And so far, we haven't heard otherwise. The kid's getting more physical therapy. I think there's some medication as far as neurogenic stuff to look at, but that history was helpful. The prior trauma, it was minor trauma, and eventually in pain and discomfort more distally to the area of injury. So I think that's what this is: complex regional pain syndrome. Typically, it affects the extremities, the hands and the feet. And again, we have to realize this really is a clinical diagnosis. The antecedent history of injury or even immobilization, and a lot of times is idiopathic, and the location, the hands and the feet. Like I said, imaging itself has nothing really to offer. It could be corroborative. You could do a bone scan, and maybe the bone scan will show increased uptake in all three phases, with the delayed imaging showing increased uptake in the periarticular area diffusely. That seems to be the most quote-unquote specific, but even then, it's not great. So even if you have completely normal plain films, MRI, nuclear medicine, it could still be this sort of complex regional pain syndrome. And this is sort of a little summary about what I just talked about. As far as bone marrow goes, it's often patchy marrow signal edema. It can be more confluent. You want to look for soft tissue edema and enhancement because it affects global tissues, not just the bones, but also the soft tissue, the muscles. The skin thickening is typically from the edema, and sometimes you can even have changes that look like arthritis with synovial hypertrophy enhancement and joint effusion. And finally, nuclear medicine. Like I mentioned, you have all three phase uptake with diffuse juxtaarticular uptake. All right, so that's case number one. Before I go to case number two, I want to see if somebody else wants to show, because my case number two and case number three are going to be companion cases. So I'd like to do those together. Carl, do you?
Nash?
Yeah.
It's Jerry. Hey,
Oh,
one
hey,
thing
Jerry.
about the RSD.
Yeah.
One thing about the RSD case is that two things. We used to actually have a clinic here that they disbanded, unfortunately. But in that clinic, there was not just PT, but there was also biofeedback and psychiatric stuff. And the
Yes,
kids
you're
who
right.
went to the clinic did really well. It got the first time.
Yeah, you're right.
The other thing is that I don't know why, but my age group for this is 8 to 13-year-old girls.
Hmm.
I don't know why.
Yeah. Well, mine was close. Mine was about 15-year-old, but it was a boy and not a girl.
Yeah.
And we've a couple of cases come through, and we've got this pretty renowned foot surgeon here, and he seems to see a lot of them, and he says he's seen a lot of benefit from a referral to psychiatry. So sort of going back to I think what Jerry was saying about neurofeedback and things like that.
I have a question though. I
Yeah.
mean, how do you differentiate between, how when you have osteopenia, like disuse,
Yeah.
that also shows up as on MR as, bright signal on fluid sensitive sequences.
Yeah, I think, Amisha, it can be a little
Versus when
difficult.
you have,
I think it can be a little difficult. What I look for is sort of edema elsewhere than just in the bones. And again, none of this is specific or sensitive, but the few cases I have seen, if I start to see edema in the soft tissues, muscles, subcutaneous tissues, and the history is appropriate. For example, I think of disuse osteopenia as somebody who just is immobilized, is not using their extremity at all. It's they've had a fracture, so they're immobilized. But this person, I did see some soft tissue edema. There was a history of injury, but it wasn't a big injury, and they were not really immobile from it. So I think we have to rely a little bit on our clinical colleagues too. Any other thoughts?
Amisha? When you look at disuse osteopenia, it's actually not a good term. And if you change the term, it's a little bit more intelligible. So when you look at a fracture, people get osteopenia at the level of the fracture and distal. So it's not really disuse because let's just say you have a distal tibial fracture. The whole tibia is not being used. But the osteopenia starts at the fracture and distal because it's actually ramping up the sympathetic axis. Abnormally ramped up sympathetic axis is exactly what RSD is. So they're kind of one and the same thing, except one is abnormal and one is normal.
yeah, okay.
Thanks, Jerry. Any other comments?
Mahesh, what is that on the talus? I keep looking on your MRI. Is that little line near the talar dome anteriorly?
Talar dome anteriorly. This?
Yeah, that little. No, just a bit further anterior on the T1s.
Oh, the T1s. Here?
Yeah. This one here.
Yeah, I don't know. It could be I don't have the other images, but I don't think we diagnosed a fracture here, like a insufficiency fracture. If that's what you're thinking.
Yeah, and I was just saying our orthopedic surgeons prefer us not to use insufficiency fracture, to say stress injury or something, because they're worried that then the kids will immobilize and then they get this. I don't know, it's a tricky one.
Yeah. No, we look for that, and even on the stir here, the signal isn't concentrated around this line. It's sort of diffusely present. So I don't think there's any more fluid right around that line than there is anywhere else in the affected bones.
So, Jerry, how would you phrase the right terminology for patient not using the ankle? Would you use as osteoporosis, or how would you?
Jerry, did you hear the question?
Sorry about that. Yeah, I have my mute off.
Oh, no.
I actually do call it disuse osteopenia because it's just not worth educating people. But in my brain, I know that it's not really disuse, that it's really a sympathetic axis issue. And then when it becomes abnormally, it's unopposed and it becomes abnormal, then I start calling it CRPS. Does that make sense?
Yeah.
Yeah, thank you. I mean, I have seen patients who gone through MRIs, and I don't see anything other than some patchy edema. But their X-rays usually look very normal density. They have gone through multiple physical therapy. They are back to the normal physical activity, but they constant complaint of pain. And their X-ray doesn't look this bad. What right now that this case is.
Okay, some people worse than others. Here, and by the way, that the dent in the talus is only because of the plane that they're in. When you go out more laterally, if you look at a real talus, that's the way it looks.
Okay.
Yeah.
For talus. Yeah, he's getting out sagittally. You can see he's already got the anterior process of the calcaneus there.
So this was a teenager who came in a few months ago during the winter with a knee injury while sledding behind a four-wheeler or an ATV. And specifically, the injury was described as he hit a rock with his anterior tibia while he was sledding. So that mechanism will become important. So here's the initial radiographs, and on the AP view, there's really not a whole lot to see other than some soft tissue swelling, and it's a little hard to tell if, it's not obvious that there's any bone fragment here around the central portion of the knee, but on the lateral view, then not only do you see soft tissue swelling fairly diffusely with an effusion, there's at least one sort of longitudinal bone fragment posteriorly here with some adjacent soft tissue swelling. So patient had those radiographs and this CT were obtained at an outside facility before the patient was transferred to us. So the CT scan then gives you a little bit more information. So first you can see the lipohemarthrosis here in the knee. What you can also see now is that there's some complexity to this fracture fragment posteriorly, and it's generally living in the region where you would expect the posterior cruciate ligament to attach. And in fact, without giving you soft tissue windows, you can see portions of the proximal PCL here along the intercondylar notch. And then there's some fragmentation that extends through the posterior tibial plateau, not quite to the physis, but almost, and it's a little bit comminuted here. So everything thus far is suggesting that there's likely an avulsion injury of the PCL. So I'm going to switch over to the PACS here, and hopefully you can see this. So these are fat-suppressed T2 weighted images, and as we scroll through, there's quite a bit of soft tissue edema here posteriorly with what looks like capsular injury, and there's a bit of fluid tracking posterior the popliteus here. The ACL looks pretty good. There's clearly a lot of edema within the tibial plateau, and now you can tell that you've got sort of an abnormal morphology of the PCL, and here's an interruption of the dorsal aspect of the proximal tibial epiphysis, and we've got elevation of a bone fragment here from the site of interruption. So I wanted to show, we do these pretty routinely for most of our joints, these 3D proton density weighted images without fat suppression. And we, let's see. I've had something happen here that must be related to someone else logging in. So let me try this. Okay, here we go. So scrolling through these sagittal images, now you can see the bone fragment here attached to the dysmorphic posterior cruciate ligament. And you can't really tell the degree of fragmentation of the bone here, but it's very clear at this point that what's going on. There are some other things to point out. We've got probably a little bit of cartilage injury here anteriorly along the femoral condyle. As you scroll back and forth, and it's a little hard, the particular settling of the blood products here against that cartilage is similar signal intensity, but you can tell other areas where it's more continuous and normal in appearance as compared to this particular area. But so this is a PCL avulsion, and things I just wanted to discuss about it, and I've actually got a companion case to go with it that's a little bit different. Similar to ACL avulsions in skeletally immature patients, avulsion injuries are more common than pure mid-substance ligamentous injuries, and they can be at the distal attachment or at the proximal attachment, and can involve varying degrees of bone, cartilage, or neither. You can actually have just complete disruption of the fibers at the cartilaginous attachment. There's a fair bit of literature about how to fix these, and it's kind of all over the place. Traditionally, the literature says, orthopedic literature says, if there's no significant displacement, and nobody's really defined that well in the articles I could see, but presuming less than 1 to 2 millimeters, that conservative therapy is very reasonable. Depending where the site of injury is and the state of skeletal immaturity, other options may be invoked surgically. And things to keep in mind are that if there is more ligamentous injury that requires graft, then keeping the integrity of the open physis, some sort of physeal sparing procedure is sometimes invoked. So there is some literature that says, depending on the specific type of intervention, that may not be as critical as it once was thought. But I can't find very much consensus. These are relatively rare injuries compared to ACL injuries in kids. So there's not a definite classification system or a widely agreed upon surgical approach compared to ACL injuries. Any comments, thoughts, discussions? I mean, we see these, I feel like maybe one a year, maybe.
That's interesting, Carl.
Carl out laterally.
Go ahead, Jerry.
Carl, can you scroll out laterally? I think that's Riceburg posteriorly, and then I think it kind of disappears. I'm just curious.
Yeah, we definitely have some Riceburg here, absolutely.
Looks like it never really attaches to the close. Okay. Yeah, it never really attaches to the posterior horn.
Yeah, right.
I'm getting busy.
Yeah, sorry, I'm scrolling faster than probably the frame rate is on, so.
No worries.
Yeah, so Carl, I was going to say, I think it probably applies to PCL also as opposed to ACL injuries. You sort of mentioned how in the skeletally immature kid, we tend more so than adults to fail at the level of attachment. So you have a bony avulsion rather than frankly ACL injury. And anytime I say that, I used to tell people, oh yeah, the ACL looks fine and the PCL looks fine and there's the bony avulsion. So going to these orthopedic conferences and talking to a lot of sports medicine people, about half these kids who have an ACL avulsion injury will eventually come back and they'll tear their ACL. So they're believing that, yes, it failed at the attachment site with the bone, but there's probably a significant amount of injury that's also happened to the ligament itself, such that they're really weakened, and even minor injury later on can lead to a complete rupture. So I think we have to start thinking about, in terms of not just one or the other, it's probably both are injured at at a certain point. If half these kids are coming back with ACL tears also later on.
What about the MCL and the other stuff? Those are okay?
Well, the only thing that they talked about was the ACL. Because we see so many ACL tears there, we see so many avulsions, and they even showed me some arthroscopic views where they went and tried to tack down the avulsion site of the tibial spine, and then you could just see that the ACL was very, very floppy. That the integrity there wasn't as what you'd expect from a normal ACL. So it does get stretched, and there's probably a lot of internal damage that's been done that we can't quite pick up on the MR.
This is a very nice case, Carl. Can I ask you the question on that 3D PD image sequence?
Sure.
Which scanner is this, a Siemens or?
This is a Philips, and it is a 3 Tesla in this particular case. I will say that our 1.5s, and I think the companion case actually shows this. Our 1.5 as far as the quality is variable. Particularly our GE scanners at 1.5 aren't quite as good, but we've been very happy with the Vista, the 3D proton density on Philips. And it is kind of as with everything MR, it's sort of a balance of image quality versus time.
Is it faster for you? Is it something that it is you reformat also in the different places? Like, what do you do with the 3D?
Yeah, we do reformat, and I love it personally for meniscus and for articular cartilage.
Yeah.
But we are not, it's sort of in conjunction with rather than substitution for. I feel like on our 3T, we could definitely substitute it. In our 1.5s, it's a little hit or miss sometimes. So I don't think we're quite to that level of fully, being ready to not primarily acquire other planes.
Oh, okay.
One other thing I was just going to say, and this is related to the mechanism. So the classic history is a blow to the anterior tibia. So the classic car accident situation is a dashboard type injury of the knee, but it can be seen with other mechanisms such as hyperflexion and severe hyperextension. Thus, the history of hitting the rock with the anterior tibia while sledding, I think, becomes relevant in this case.
Great, thanks, Carl.
And as you mentioned about the preserving the physis of the proximal tibia, I don't know. I think the proximal tibia doesn't contribute so much to the linear growth of the bone as much as the distal tibia is. And when they do ACL reconstructions, they do use the tibial physis is kind of always involved, but they try to preserve the distal femoral physis.
Yeah, that's a very good point. Thank you.
So these are 3 cases, just all good illustrations, really. Nothing earth-shattering here. So the good, the bad, and the ugly.
Sounds like us, you, me, and Carl.
I just want to elaborate good too. The Jerry is definitely the good. So anyway, here's the good, and it's an expansile lesion in the proximal fibula with a mature varus reaction. There's a little non-ossified fibroma up there that's probably going to annoy everyone. And he had some pain and a swelling. He's a 14-year-old boy. You can see it looks reasonably well-defined and the varus reaction reasonably mature. So I suggest that even though it's expansile, it's probably relatively slow growing. And the MRI probably doesn't really help because there's a lot of edema, but he probably had a pathologic fracture through it, why I presented with the pain. You can see it's got fluid levels and expansile lesions, so it's thought to be an aneurysmal bone cyst, which is what it turned out to be. So that's the first case. The next case, sorry, it's super zoomed up there, just so you can appreciate it. A lesion in the lateral clavicle. You can see with this lesion, it's sort of got a very wispy, sort of difficult to see margin. Almost see strands of the lesion extending out. And here, it has a Codman's triangle. The margin's not that well defined, either end. So the MRIs from externally just showing the same sort of appearance with extensive edema, periosteal reaction, and you can see the fluid level here. So she went on to have an ultrasound guided biopsy, which showed it was an aneurysmal, suggested it was an aneurysmal bone cyst. But then a follow-up 2 months later showed the lesion had increased dramatically in size, and you can see that Codman's triangle appearance again. It looks a little bit better defined now. So they decided to curette the lesion out, which they did, but then came for a follow-up radiograph and it looked like that. So that was 5 months after the biopsy and 3 months after the curette. And you see even though there's that periosteal reaction is markedly elevated, but it looks a bit more mature now. The MRI just shows an extensive lesion with fluid levels. So
That's the best fluid level I've ever seen in my life. Jesus.
And there's some concern that there may have been some soft tissue component with it here. So it was ended up completely excised, and it turned out to still be an ABC and thought to be an aggressive behaving ABC. I'll just go to the last case and we can discuss them all at once. And so here's a third case, a 10-year-old female, lesion in the distal tibia. Sorry, this came from externally, so I'm not sure how she presented. But again, you can see there's this expansion and periosteal reaction and a Codman's triangle appearance, poorly defined margin. And probably what's more concerning is you wonder if it's crossing the physis here. And again, you see extensive fluid levels, and the T2 confirms that it is crossing the physis, so it's extending into the epiphysis. There probably is a little bit of effacement of the adjacent fibula, so it's probably been there for a little while. And this turned out to be a telangiectatic osteosarcoma. And these cases all came in within about 2 months of each other. So I just thought they were a good illustration of their appearance was that predicted their behavior was illustrated by their appearance. So this is a good one, which had a relatively indolent appearance, even though it was an expansile lesion. This one was somewhere in between, and this one had an aggressive appearance and was crossing the physis and turned out to be very bad. And the only other point I want to make about this case is this is my list of transphyseal lesions, which osteosarcoma is one of them. I don't know, has anyone ever seen an aneurysmal bone cyst across the physis?
Does the triradiate cartilage count?
Yeah, good question.
Because I've seen that.
Okay.
Yeah, I've seen one in the distal elbow in a younger child that was crossing the physis, also breaking out into the joint.
Okay, so that doesn't mean it's not an aneurysmal bone cyst, so it's just a differential, really. And has anyone had any comments about such an aggressive behavior in aneurysmal bone cyst? And it looks like it was aggressive before we started putting needles into it, but definitely got aggressive after that.
So these the aneurysm bone cysts, were they primary or secondary? Was there another lesion associated with them? Do you know?
Well, I guess the one person did have a non-ossified fibroma in the proximal tibia, but no, they didn't find any other lesions with these, so they were all primary in inverted commas, but there was no other lesions seen.
Cool.
Karen, did you do a post-contrast imaging?
What was that, Jerry?
Did you do post-contrast imaging, especially the clavicular lesion?
The clavicular lesion, I think.
Oh, that is post-contrast.
This was post-contrast.
Surprising amount of soft tissue enhancing there.
Yeah.
Well, this is the one that was violated, right? That was already biopsied?
It had been biopsied and it had been curetted, that's correct.
Yeah, that makes it hard.
Case 2. So we have 2 companion cases. And I want to share this with you guys, and I think the audience in general throughout Peds land. This is something we see relatively frequently at Seattle Children's, mainly because we've got this world-class foot surgeon. And I wanted to show you, this is a skeletal immature child, and we're looking at a lateral view. Obviously, this one is maximum plantar flexion. It's difficult to tell. I don't know if the resolutions comes through or not, but there is this is maximum dorsiflexion. There's a wrap, there's a cloth wrap around the forefoot here, and they're pulling up in this direction on the forefoot to cause this sort of maximum dorsiflexion view. And on the right, the same wrap is now trajectory is the opposite direction towards the ground. So this is a maximum plantar flexion view. And so why do we get these views, right? We're looking to see what the relationship of the talus and navicular are. So if you look at this bone on the left, here's your talus, here's your calcaneus, and a lot of people say, well, is that the navicular? Well, that's not the navicular, because we know the navicular is the last bone in the foot to ossify. So this is actually part of your cuneiform complex. But what we do know is that the navicular ossifies on the lateral view along the same plane as your cuneiform. So it would be somewhere over here, and I'll show you a diagram of that. So at this point, the talus is oriented more vertical than normal. We can't quite say it's the vertical talus yet, but it's more vertical than expected. And as we look over here, that verticality is less conspicuous. So what does that mean? So if we assume then the unossified navicular is over here, there is no way in God's good earth that this talus is articulating with your navicular bone in the maximal dorsiflexion view. However, when we now do a maximal plantar flexion view, we can reestablish that orientation between the talus and the navicular. So when we can do that between the maximum dorsiflexion view and the plantar flexion view, we call this a congenital oblique talus. So this is case number 2, and I want to go right to case number 3 because it helps illustrate the difference between this and the other important entity that we want to distinguish between. So here, very similar, this is a plantar flexion view, except now we've got a plexiglass or some plate at the bottom of the foot pushing it up, the forefoot up. And if you look, it's a little difficult to see, but we can work it out. Here is our talus, here is our calcaneus, this is probably our cuboid. None of the cuneiforms are ossified except maybe this one. I don't know if this is crucial, but there's a faint ossification center right over here. So we know that our navicular is going to be somewhere over here. Again, no way that this navicular is going to be ossified with your talus. When we do the dorsiflexion, the plantar flexion view on the right, where we have the plexiglass on top of the foot pushing it down, again, you can see here's a faint calcification or ossification of your cuneiform, and we know that the navicular ossifies along the same plane here as our cuneiform, so it would be somewhere over here. So between dorsiflexion and plantar flexion, there's no appreciable relocation, or we can't reestablish that articulation between the talus and the navicular. So when that happens, we call this a congenital vertical talus. So it's important to distinguish that because the treatment is different. Oftentimes with vertical talus, it means that they'll probably have to do some surgery to correct this abnormality, as opposed to if it's a congenital oblique talus, they can probably get away with serial casting and things like that. So we see quite a bit of that, and we've taught our radiologists to look for these particular conditions and not confuse the two. And so when you get these dorsiflexion and plantar flexion view, that's what you're typically looking for. Okay, anybody have questions about this? Comments?
Mahesh, can you go back on that first case?
Sure.
Just want to understand the difference between the two.
Yeah, so here in the dorsiflexion view, you notice that the talus is not articulating with your navicular. So, but when you do a plantar flexion view, you can reestablish that connection between the articular surface of the talus and the articular surface or the proximal articular surface of your navicular, as opposed
this is called as
congenital oblique talus. Right, exactly. So on the lateral view, all these feet, both these conditions look like a valgus type of deformity because you've got sort of a downward sloping of your talus. So they both look like a hindfoot valgus. But this goes beyond just hindfoot valgus. It is associated with either a congenital on the hindfoot. If it's a purely hindfoot valgus, you always have a establishment in the lateral view between your talus and your navicular. So even the maximum plantar, dorsiflank, whatever, you're always going to have an articulation between your talus and your navicular. And that's pure hindfoot valgus. Now, if you have this disarticulation between the talus and the navicular, and you can reestablish that disarticulation, then it's oblique talus. And if that disarticulation cannot be reestablished between the plantar flexion or dorsiflexion view, then it's a congenital vertical talus.
Has anyone tried ultrasound for this?
We're talking about doing ultrasound for this. In fact, we're trying to do a lot more ultrasound for just club feet and planovalgus and all this stuff in general. So we have not done, and I haven't found anything in the literature for this.
I tried a couple times.
Did you?
Fun. Not
Yeah.
hard.
Okay, good. Maybe I'll call you when we start establishing it here. Anybody have questions or comments about this?
What is the management difference? Is it surgical management difference?
Yeah, typically, so now they're even if it's a vertical talus, some places are trying serial casting for it, but it has a lot less success than if it's congenital oblique talus, because basically by manipulating the foot, you can reestablish that connection, right? But the vertical talus, no matter what you do with the foot, you can't reestablish that connection. They would need a surgical treatment for that.
Yep.
Yeah.
Yeah, see ya.
All right, so this limb length discrepancy radiograph was obtained in this child with this obvious congenital deformity. And, it's a little hard to assess the exact complement of bones here, but it's clear that in the lower leg on the left that we're really only seeing one bone. And one of the things that I sort of found out reading more about this entity is that, if you only see one, it can be difficult to tell. Are we looking at tibial hemimelia or fibular hemimelia? So which bone is present versus absent? And so the tibia, if it is present, it should be still articulating with the distal femur, so it tends to be more centrally positioned, whereas particularly on any sort of simulated weight-bearing image, the fibula will override the knee because it will be laterally positioned. Now, I realize we don't have a great AP or lateral assessment here, and it's important to try to sort of look for additional anomalies more distally, which will be revealed in our MRI, but so this patient was being evaluated by orthopedics for potential for surgical management and was suspected to be heading towards a disarticulation at the knee, though sometimes you'll get an MRI request potentially to see, what the status of the knee is with regards to structures that are present or absent, and also to help sort of evaluate other anomalies that may potentially alter their surgery. So when we got this request for doing an MRI of the lower leg, we're sort of rolling around different ways to approach this. What sequences are going to be most useful? Thinking about, some general, as best we can, some anatomic sequences, just T1 without fat sat, and probably some fluid sensitive sequences. But it sort of came to me that perhaps one of the best things we could do is get some 3D imaging using that proton density VISTA or cube or space sequence that we were looking at earlier. So these are just coronal stir images, and basically acquired in the same plane with more anatomic positioning of the contralateral right lower extremity, which I wanted to include to help have some comparison for structures on the left. And we're actually going through more laterally the fibula here. And then it's a little bit difficult to tell, particularly on these static, but 2D images, exactly what's going on here more medially within the lower leg. So we did get these 3D proton density sequences, and I found them particularly helpful for understanding what was going on here within the knee and beyond the knee. So we could see the fibula here with unossified cartilaginous epiphyses, and as we move more medially, this is actually an unossified block of tibial cartilage, and that is connected to the distal femur by a single cruciate ligament. And there's no visible patella, and you can get an idea of the sort of ankle joint configuration. There's also, I'm not going to count them out, but there is preaxial polydactyly in this case as well. But I found this quite helpful to add sort of a 3D sequence in to get an assessment of cartilage, ligaments, and visible ossified structures. And they did ultimately wind up doing disarticulation in this through the knee joint and did comment on a single cruciate ligament. So I don't know if anybody else has sort of a cookbook method for when you get a request from orthopedics looking for some sort of underlying assessment of soft tissue and unossified structures in a patient with a limb deficiency or other congenital limb abnormality. If you have a specific way you approach it, I certainly would be interested in hearing that. But this was particularly helpful for us, and we did go up and we were able to reformat these. So here's sorry, that's not the reformatted. Sorry, here's our reformatted images. And so it's sort of more sagittal to the femur, but more coronal to the lower leg in this particular set of images. Any comments, thoughts?
Do you do any gradient cartilage sequences? That will also show it.
Yeah, that's a good point. We did not in this particular case, but no, that's an excellent point. These can also be associated with vessel abnormalities, so I think it's worthwhile to throw in. We didn't do any sort of post-contrast sequence to look for vessels, but we did do a 2D time of flight imaging to get some assessment of the vessels.
That's a great use of 3D, Carl.
Carl, do you think that's the anterior or the posterior cruciate?
I think it's the middle cruciate. I don't know. I mean, it's certainly straight like you would expect an anterior cruciate ligament to be, but I mean, all the other anatomy is so abnormal. I don't know that I can really say.
I wondered, do the cruciate ligaments come from a single structure and then they divide, or are they two separate? They already started two separate. If it's maybe it's the same ACL and PCL that hasn't divided yet, or didn't divide.
Yeah, I would have to leave that question for Jerry.
That's right.
Sounds like a Jerry question.
Awesome.
Carl, you seem to love this 3D PD images sequence.
Yeah, I think it's, we worked with our physicists quite a bit a few years ago to try to optimize it. And I will say I find it very useful. The other thing you'll notice is that you get really nice flow voids within your vessels too. And so it can be helpful for answering some vascular questions, and probably was more utility in this particular case related to the vessels than our time of flight was. But yeah, I found it useful in a number of circumstances.
Yeah, it looks pretty nice. Mahesh, to give your question about the ACL and PCL development,
Yeah.
I had when I had submitted an article, a case report for one of the bilateral absent cruciate ligament, I had looked up some embryological literature, and I forget now what was the development. I don't remember, but they do have a very early development in gestational, like the fetal development. They are actually though two different time frame. Very early, but still two different time frame.
Interesting.
So patients can have absence of both or presence of PCL, but not the ACL. I forget. I have to look up and let you know.
Cool. Thank you. Kieran, any more?
One I've got a bit like Carl's that's been sitting there for a little while.
All right, let's do it. We've got 5 minutes left.
It's a quick one.
Good.
Very quick.
Perfect.
It's just a 13-year-old female with a lump in the middle finger. And the ultrasound had just showed a little hypoechoic lesion. And the MRI, I think it's pretty non-specific. Here's T1. See the soft tumors there, rather well defined. It looks like it's next to the fingernail. See the skin overline looks normal. Here's a T2, and here's the post-contrast. It's diffusely enhancing. And it's not shown that well, but you see the same sort of appearance in the coronal images. So, I guess just common things, it could be dermoid, but it looks like it's diffusely enhancing a giant cell tumor, or maybe a fibrous tumor. And this turned out to be an epitheleoid sarcoma. So I guess it's just a good case to illustrate you don't want to try and get specific with soft tissue lesions. Everything can be a sarcoma, really.
Wow. Do you guys have a finger coil? Anybody have finger coil out there?
This is not a finger coil.
No, I know. But, I mean, Carl, do you have a finger coil?
Not to my knowledge.
No, okay. I'm wondering, I feel like every time we get MR of the hands and some peripheral lesion, I feel like I'm doing everybody a disservice because I just basically, oh, look, there's a little soft tissue, something maybe too small to characterize. And I'm wondering if it's worth getting a finger coil.
The last case I did for small parts where I really needed something high detail in a very small area was like a 2-week-old who had a soft tissue lesion. I may have actually shown it a few months ago of the hand extending into one of the fingers, so it wasn't distal in the finger, but we just used the wrist coil and got really nice images. We did do it at 3 Tesla, but that's kind of the smallest field of view I've done in a while.
Do you ever look for, sometimes we get, MRs for injuries, collateral ligament injuries. Or,
Yeah, right.
And so I figure, I know Andy Z had this nice talk on the hand, at our SPR stuff, that SPR MSK. And I thought maybe he'd done that work in Cincinnati because it looked like he was using finger coils.
I think...
Or maybe he took it with him when he left.
That's very possible.
Just to add into the PCL development and ACL. So it is post-ovulation 7 to 10 weeks of zone, articular interzone around 7 to 10 weeks post-ovulation. Okay. And the first PCL is the first to develop, followed by the ACL. And the meniscal development goes along with the cruciate ligament. You can have the hypoplasia, or you can have a complete absence. But there are 3 types of hypoplasia and dysplasia of the ACL and PCL.
Cool.
And in type 1 is, hold on, where is the type 1? Here. The type 1 has hypoplasia or aplasia of ACL with normal PCL. Type 2 has ACL absent, but the PCL is hypoplastic. And type 3 has both the ACL and PCL aplasia, no development.
So the fact that we see one big structure, given the fact
Has
that
to be
these are treated, is
PCL.
probably PCL, right?
Right.
Yeah. There you go, Carl.
All right.
All right.
Thanks,
Thank you,
everybody.
guys.
Okay, thank you.
Thank you, everyone.
Bye, guys.
Well, everyone.
Bye.
Bye.